And thank you for joining the National Clinician Consultation Center's Clinical Technical Assistance Office Hours. My name is Brenda Goldhammer, and I'm the Program Director of the NCCC. Today's presentation will be about aging, substance use, and cognitive health. Before we begin, we have a few housekeeping items. First, we kindly ask that you please mute yourself throughout the webinar presentation today. On the bottom of your screen, there's an option for Q&A for you to submit any questions you have for our presenters. We kindly ask that you please use the Q&A rather than chat for questions. Our presenters today include Dr. Christy Soren and Dr. Trevani DeFries. Dr. Soren is an assistant professor of medicine in the Division of General Internal Medicine at San Francisco General Hospital. She is a primary care clinician and educator in the Richard Fine People's Clinic at SFGH and the medical director at the Outpatient Buprenorphine Induction Clinic through the Substance Use and Addiction Medicine. Dr. DeFries is an assistant clinical professor of internal medicine at UCSF, where she also completed a fellowship in primary care addiction medicine. She's an internist and an addiction medicine physician at San Francisco General's General Medicine Primary Care Clinic and attends on the hospital's inpatient addiction medicine consult service. She also works as a clinician consultant for the NCCC, our substance use warm line, and she's been doing so since 2019. If you're a healthcare provider and you have questions that we are unable to get to today, please consider calling our substance use warm line, where you can speak with Dr. DeFries along with our other clinician consultants. Our webinars and the Substance Use Warm Line are supported by the Health Resources and Services Administration's HIV/AIDS Bureau and Bureau of Primary Healthcare. Before I turn over our webinar to Dr. Soren and DeFries, I will be next turning over the presentation to Laura Chassaw to tell us more about HRSA BPHC. Before doing so, I just also wanted to thank the National Alliance for HIV Education and Workforce Development, along with the Opioid Response Network, for partnering with us to provide continuing education. We also want everyone to let everyone know about their next webinar that will be happening tomorrow for their Bridging HIV and Substance Use Disorder Innovations. Please kindly mute yourself. Innovations in the Field webinar series. It's going to be taking place tomorrow, and it will be on the role of the overdose prevention centers in responding to the overdose and infectious diseases crises in the United States. It will be presented tomorrow at 12 p.m. Eastern by Brandon Marshall, PhD. He will be discussing how overdose prevention centers are an evidence-based strategy to prevent overdoses and reduce HIV and Hep C transmission among people who use drugs. I do believe a link has been dropped in the chat for anyone that might be interested. Next, we'll turn over the presentation to Laura. Thank you.
Thank you so much, and welcome everyone. It is amazing to see so many people here for this really important talk. I've been looking forward for this since the warm line first started reporting the uptick in the calls from people from the regarding aging population. And next slide, please. At the Bureau of Primary Healthcare, and next slide. The Bureau of Primary Healthcare, we last year, or in 2021, we treated over 30 million patients, and we have found that the proportion of our patient population that is 65 plus just continues to grow, and that as that continues to grow, we need to make sure that we are serving that population and meeting their needs. Next slide, please. And in addition to our aging population growing, we also are seeing growth in patients who are receiving medication for opioid use disorder. We are seeing increased referrals through referrals in patients receiving expert, increase in patients receiving MOUD, and an increase in MOUD eligible providers. And we really appreciate both this presentation, but also the warm lines, the NCCC's continued assistance as we continue to come across new cases and have questions. And so with that, I'll turn it over to the doctors. Thank you.
Thank you so much. I hope everyone can see the slides okay. We'll just start off letting you know about what the learning objectives for our webinar today are. We hope that by the end of today, you'll be able to identify the impact of substance use on older adults, especially those with cognitive impairment. That's really going to be our focus today. We hope you'll be able to incorporate a workup for substance use for an older adult with cognitive impairment and adapt treatment for them. And so we're going to first review a little bit about epidemiology to help understand the problem that we'll be discussing today. Why is it important for us to be talking about this, to assess unhealthy substance use among older adults? Well, we now have the largest group of older persons in the history of the United States, and as they age, more presentations and complications of substance use are going to be seen. And substance use disorder is on the rise in this rapidly aging population, as you heard, and it's projected to increase. And this may be due to several different factors, including the aging of the baby boomer generation, who have changing attitudes towards substance use compared to previous generations. And then those who were more likely to have used substances or had a substance use disorder when younger continue later into life. And as people age, they're more likely to have negative effects of drugs and alcohol from comorbidities or interacting medications that they might now be taking. It's important to remember that most people over 65 do not use illicit drugs, but almost 20% of older adults misuse alcohol, over-the-counter medicines, and prescription drugs. And this is often unintentional. And alcohol is the most commonly misused substance in this population. So for older adults, data does show now that there are harms of this. Harms are on the rise in the form of hospital admissions, and as this graph shows, in overdose rates. And we know that substance use impacts people from all different backgrounds, but we see the harms, especially of overdose, disproportionately affect people of color and people from minoritized backgrounds. So I'll turn it over to my colleague, Christy, to tell us how substances affect the brain.
Thank you, Trevani, and it's so exciting to see people from across the country here. Yes, let's talk a little bit about when someone's using a substance, how it has acute and chronic effects. Next slide, please. So we know in the acute setting, when someone's intoxicated, it alters judgment, impacts memory and attention, and people often act with disinhibited behavior. And we know these effects can be more pronounced in individuals who have cognitive impairment. And then with chronic use, our brain adapts. So we have changes in metabolism, blood flow, receptor regulation, neuronal connections, and epigenetics. And because of these neuroadaptations, this fosters a cycle of cravings, binge, and withdrawal syndromes. And then over time, there are chronic effects on the brain, including in the areas of cognitive domains, executive function, memory, and attention. But let's talk a little bit more about the effects of the older brain and then aging brain. So for older adults, the acute effects may be more pronounced, and this could be because older adults metabolize all substances, including alcohol and other drugs, more slowly. Their metabolism has changed, leaner body masses, and so even with smaller or even the same amount of use may have a stronger effect in the acute setting. We also know there can be interactions with medications. Someone may be at risk of falls, which can be heightened when they're acutely intoxicated and disinhibited. And then we know as all of us age, we increase our comorbidities. And so those comorbidities can be worsened by substance use as well. And then if someone is experiencing cognitive impairment, it could impact their ability to use the substance in a safer way. And so someone may forget how much they consumed, may forget to eat, or may forget about some of the things they do to create a safe setting to use a substance. Next slide. But what do we know about, do alcohol and drugs cause cognitive impairment? Do they cause dementia? The vast majority of our evidence comes from alcohol. And we do know that alcohol chronic use negatively impacts memory and can increase the risk of dementia. Heavy drinking is associated with higher rates of cognitive problems and Alzheimer's disease. Light to moderate drinking can increase someone's risk of progressing to dementia if they're already having mild cognitive impairment. And then we also know if someone's having cognitive impairment, their symptoms of memory and attention can be worsened by ongoing alcohol use. For those using benzodiazepines, there's an association with any benzodiazepine use with a higher risk of dementia when we compare to people who've never used benzodiazepines. And then for tobacco, current smokers are higher risk of developing dementia as compared to those who never or formerly smoked. We have a lot less information about the chronic effects of stimulants and opioids and cannabis on its impact on dementia and cognitive impairment. There's not a lot of evidence. It's inconsistent, although there is some suggestion that chronic use over time can result in cognitive impairment. And I think it's just a lack of evidence for us to really have a conclusive answer to that question. Next slide, please. I'll turn it back to Triveni to talk about how do we assess more for substance use in an older adult and especially those with cognitive problems.
So we understand a little more about how substances can impact the aging brain in important ways. And so as Christy said, let's talk about how to assess for substance use in an older person. And we're really going to focus, as you've heard today, about those who are co-experiencing cognitive impairments, because it's such a common area of challenge. And today we're not teaching you how to do a screening for dementia, and rather we're going to focus more on the workup of substance use in this context. But I want to direct you to a great approach for screening that can be used in primary care and can be used in somebody who has a substance use disorder. And it's called the Cognitive Health Assessment. You can learn more about it at Dementia Care Aware, which is a program based in California, but has great resources accessible, and they're online. The website's right here. And the approach consists of first taking a brief cognitive health history with an annual screening question, or maybe it's an observation by a care partner who's in clinic that's worried about memory decline. And then you can assess both cognitive and functional decline using screening tools. And the website will give you a list of those recommended tools, but there are things like the mini-cog or GP-cog and the ADLs and IADLs. And then lastly, you identify and document a care partner. So you can do this cognitive health assessment for a patient with a substance use disorder, and you don't need to delay it if they have an active use disorder. If they are actively and acutely intoxicated or in withdrawal, you may have to discuss it a different day, but don't delay your assessment. So let's start with a case that we're going to explore for the rest of the webinar. This is the case of Jessie, who is a 72-year-old patient who presents to your primary care visit with their adult daughter, and they're there with some concerns about memory and cognitive challenges. And at your last visit, you actually did the cognitive health assessment, and today they're here for some further assessment. So an adult like Jessie, who's older, when they experience unhealthy use of substances, usually they are under-identified, underdiagnosed, and undertreated in healthcare. Experts have even called older adults an invisible population, even though they're having more frequent healthcare visits. So what makes it so challenging to recognize substance use problems in older adults? Well, many people think that substance misuse is just a young person's problem. And there's stereotypes and bias about older adults and about people with addiction or mental illness. These are really common, and it might make it hard to talk about. Stigma and shame are such common barriers to addiction treatment that we see, and older adults may have even grown up in a time when substance use or mental illness received a great deal of stigma. Older adults are also less likely to seek care in traditional addiction treatment settings, and they may be harder to diagnose with unhealthy substance use because of their cognitive impairment, functional impairment, and other medical conditions may obscure or overlap with signs of harmful substance use. So clinicians can face difficulty, and they can face difficulty applying diagnostic tools to this population and with how to engage with their caregivers. And lastly, they might face barriers of time or lack of knowledge about substance use disorder management. So hopefully we can address some of these today. Patients are going to present to you with unhealthy substance use in many different ways. Some may present via screening, some with signs or symptoms, some with concerns of a caregiver or another provider. And the goal is that there's no wrong door to assess substance use. This doesn't have to be done in a specialty addiction treatment setting or by a specialist. And so we hope to equip you with some skills today to help, because primary care is a great place for diagnosis and care of substance use disorders. Substance use occurs on a spectrum, and it spans from abstinence to riskier use, all the way to substance use disorder, when people have a problematic pattern of behaviors that lead to negative life consequences defined by the DSM-5 criteria. And as consumption increases, consequences generally become more severe. So for older adults or people with cognitive disorder, consider how things may shift on this spectrum. The same levels of use, even at lower levels, may be riskier, may have more consequences. And actually, most older adults who misuse substances do not meet the full DSM-5 criteria for a specific substance use disorder, but they may be engaging in riskier use of substances. So consider how substance use may change over an individual's lifetime on this spectrum, and how you can't assess or screen a patient once in their life, but really need to rescreen and reassess as they age. Screening detects patients that have substance use that lies in the riskier or unhealthy use part of that spectrum. And the idea is ideally to catch disease earlier and prevent progression to a more severe substance use disorder. And for people who feel uncomfortable discussing the topic of substance use, screening can really help open the conversation. And when you're doing cognitive health assessment, you can integrate a screener as one option to start the substance use assessment. And I say this as an option because it may work better for some patients rather than others. Some older patients might have limited vision, writing, or cognition to fill out a screening form. And then be aware that there are a few validated approaches that are specifically designed to screen older adults for substance use disorders. So the typical screening tools we use in clinic may have limitations in our older patients. There are no validated screeners for prescription or over-the-counter medication misuse or other drugs in this population, and we know those are important issues. So usually you need to do a more holistic assessment, and we'll try to demonstrate that for you today. And it's also important to include input from caregivers into this information gathering process. So here on this slide is an example of a validated approach that we can use to screen an older adult for specifically unhealthy alcohol use. And you can start with this question: during the past 3 months, have you had anything to drink that has alcohol in it? And then you can use a tool like the audit or short Michigan alcoholism screening to see if someone will benefit from more intervention and referral to treatment. One major limitation that you may have come across with screening approaches is that there are no known safer drinking limits in patients with cognitive disorders. So the US guidelines, which you see here in the blue chart, as well as the Audit C screening tool, these are commonly used, but they're based on quantities of alcohol that are not adjusted for patients with dementia. So US guidelines recommend the following drinking limits, and adults over 65 years old fall into the same category as women here, where no more than 3 drinks a day and no more than 7 drinks per week are recommended. And drinking over these limits has been found to be connected with health problems like an increased risk of cancer. But for people with dementia, with cognitive disorders, even 1 or 2 drinks may not be safe. So these guidelines really need to be contextualized to the individual. And the recommendation for people with cognitive disorders is that the safest level of alcohol use is none at all. One tip that can help to contextualize to the individual is to discuss standard drink amounts with your patient. So here are the different types of alcohol, and each drink here represents 1 US standard drink, which has the equivalent of 14 grams of alcohol. So using this diagram with your patient, and I bring this up on the computer screen all the time when I'm talking to patients, it really helps to quantify the amounts, and this can be a really good assessment and counseling tool. But relying on an older patient's report of just the frequency and quantity of substance use as the only indicators of their problematic use doesn't give a full picture. It doesn't tell you exactly what the consequences of that use are. So here, the Short Michigan Alcoholism Screening Test, geriatric version, that's a mouthful, is the first brief alcohol misuse screener that's developed specifically for older adults. And if a client marks 2 or more items as yes here, it suggests potential alcohol misuse. And this tool is a good example because it has more geriatrics focused questions. For example, it includes questions like, when you feel lonely, does having a drink help? Or have you increased your drinking after experiencing a loss in your life? So it's designed for a population that drinks less heavily and isn't just based on how much they drink, but really how alcohol is having a role in a different stage of their life, when their role, their function is very different. Older adults with substance use disorder are often underdiagnosed because the DSM-5 criteria do not always capture well in this population. This criteria is used to make a substance use diagnosis in the general population, but let's talk about how these criteria might not apply well to all of your older patients. So for example, tolerance, or the need to use increasing amounts of a substance to obtain the same effects, it's a key diagnostic criterion, and it shows dependence. But because of the aging process, older adults have a lower tolerance for alcohol and other drugs, and they may experience harmful effects even at lower amounts of consumption. So tolerance in an older individual doesn't necessarily translate to being dependent on the substance. Another example is the criterion of failing to fulfill major duties at work, which won't necessarily apply to your older patient who's retired. So keep in mind that these DSM-5 criteria should be interpreted in an age-appropriate manner. So how will substance use disorder actually present in your older patient with cognitive impairment? So it's important to understand the patient's overall physical health and well-being to understand this, because signs of substance use disorder, they might be mistaken for or overlap with symptoms of co-occurring medical or mental health disorders or with the natural aging process, like common conditions such as sleep problems, chronic pain, difficulty with ADLs, falls, new or exacerbated cognitive impairment, hypertension, or depression. So let's return to Jesse's presentation, to our case. So Jesse is most bothered by problems with sleep and chronic pain. He doesn't like taking medications for hypertension, and life has been hard after the death of his spouse. His daughter has noticed that he's more withdrawn, isolated, and confused recently, and she worries that he only leaves the house to purchase alcohol. You look back in his chart and you see that several years ago, there was a positive substance use screen. So our job with Jesse here is not to diagnose if substance use or alcohol use is the single cause of his cognitive impairment, but really to assess how it's playing a role in his life and in his function and cognition. And so it takes a more full assessment, and this might not happen in one visit, but really come out over time. And the assessment first involves just approaching the topic from the perspective of concern and curiosity about someone's overall health, not just their substance use itself, and asking permission before broaching the topic. Then you can characterize not just what substances someone's using, but really how they use. That means asking questions about when, how often, who are they using with, what routes of administration are they using, and what has happened in the past if they stopped using or if they used too much or even mixed more than one substance. Then you can contextualize how does the substance use really fit into their life by asking questions like, what do you like about using alcohol? What does it do for you? What concerns do you have about your substance use, if any? And in what ways would your life be different if you weren't using alcohol? How has it affected your relationships? Who do you use with? And then lastly, understand their treatment history and what their goals for change are, if any. Have you ever tried stopping or cutting back in the past? What was that like for you? What has helped? What are your goals now for your smoking? And part of your assessment should include screening for co-occurring mental health disorders. And this is because depression, anxiety, PTSD. They're so common to co-occur with substance use disorders. And their symptoms can really overlap with substance misuse and cognitive impairment. And they can make substance misuse worse if left unaddressed. In older adults, here are some tools for assessing co-occurring mental health disorders. You can use the following screens for depression. There's a geriatrics depression scale. You can also use the PHQ-9. For anxiety, the GAD-7, and for PTSD, the primary care PTSD screen, which is 5 items. And whether you're discussing substance use or mental health with a patient, it's really important to take a non-stigmatizing approach. And just like with your younger patients, these techniques and motivational interviewing strategies are important with older adults as well. So build a welcoming, respectful environment and ensure privacy, which includes asking permission before discussing any substance use with your patient and with their caregivers. And normalize that you talk to all of your patients about substance use because it really affects their overall health. Try to show empathy and concern rather than judgment or bias. And one way to do that is by using open-ended questions and statements. So things that start with tell, explain, describe to me, or questions that start with what or how rather than closed yes/no questions. You can use clinically accurate, non-stigmatizing terminology. We will try to model that throughout this presentation. So you'll notice us using terms like substance use disorder instead of abuse, or person with a substance use disorder rather than addict or alcoholic, for example. So let's talk to Jesse more about his substance use to try to really demonstrate some of these principles. And so Christy and I are actually going to attempt a short role play here. And I'm going to play the role of the clinician, and Christy will play our patient, Jesse. Okay, you ready, Christy?
Go for it.
Okay. So last visit, we talked about your memory and your thinking, and I want to talk to you about other things that can affect your thinking. And some of these things are kind of personal. Is it okay if we talk about this together with your daughter here, or would you prefer that we spend a little time one-on-one?
Sure, she can stay.
Okay, that sounds good, Jesse. Let's talk all together. I'm going to ask some questions directly to you, and then your daughter will have a chance to add anything she'd like at the end. Is it okay if we talk about your drinking and other drugs?
Yeah, I guess that's okay.
So I've noticed that for a lot of my patients, they use alcohol or drugs and it starts to impact their memory. Tell me more about your drinking.
Yeah, I guess, I've always been a drinker, but it's never been too bad. I got by, when I was working, it didn't affect my job or anything. It really isn't a big deal. I guess I started drinking more after my spouse died last year, and I used to drink every night, and I've cut back to every other night, mostly because I'm bored, I'm on my own, I don't have anything else to do. And then there's game night with my friends when I have a few drinks too.
Got it. So when you say that you're drinking, tell me about what it is that you're drinking. Like, what do you like to drink? How much?
Yeah, now it's mostly red wine, a couple glasses every now and then. Like I said, though, I've really cut back. But I guess if I'm on my own, I might finish a bottle once or twice a week. And often those nights I forget to eat dinner. It's just the wine. And I'm not driving anywhere, so it's not like I'm out and, intoxicated driving. The pours at game night can be pretty big too. So I'm not exactly sure how much I'm drinking there.
Mm-hmm. Your daughter sent me a message last week, and she told me that sometimes she calls you at night and you're slurring your words and you don't remember the conversation the next day. And she was really scared you were going to fall or hurt yourself.
I don't remember talking to her, but I know I haven't fallen.
Got it. Well, thank you so much for sharing all this information. And is it okay if I summarize what I just heard?
Yeah, of course.
Okay. You saw the need to cut back on your drinking recently, and you drink more when you're lonely, and then sometimes have trouble remembering the night before. You're here because you're trying to keep your brain as healthy as possible. Do I have that right?
Yeah, and my daughter's nodding as well. I can see she agrees and she's concerned.
Is it okay if I give you both some information about how alcohol might be affecting your brain and your health?
Yeah, I'm worried about my memory.
Yeah. So even though you've cut back, you may notice that your body's reaction to alcohol is different than before. And alcohol can make memory and thinking worse. It can even cause or worsen dementia. So it might be contributing to this and contributing to your sleep problems and high blood pressure too. So what you're describing today, it's similar to people who might be having a problem with alcohol. And we should keep checking in about your drinking, and we should really keep a close eye on any new medicines that might interact with alcohol. Since your memory problems, they've been getting worse, they've been affecting your daily life, we actually recommend not drinking at all. And that's something I'm happy to support you on.
You know, I do want to do everything I can to help my memory, and I should work on cutting back. Let me give that a try.
Okay. And scene, we're going to hold the role play there. We'll come back to it later in the presentation. So just to try to highlight some of the practices that we tried to demonstrate in the role play just then, we really tried to assess Jesse's understanding of substance use, his own perspective. We asked permission before we talked about it. We reflected back what we heard and assessed his own interest in changing substance use. We tried to provide some universal non-judgmental education, both to him and his caregiver, and kept the door open for follow-up discussions. So I'm going to move it over to Christy now, who's going to talk more about managing the plan.
Thank you, Trevani, and thanks for the applause in the chat. It's so appreciated. Let's talk a little bit more about an approach to substance use in individuals with cognitive impairment. And I'm going to focus on 4 key points. We've modeled the first, and we'll continue that, having a non-judgmental, open conversation about substance use and providing universal education, discussing harm reduction and how to reduce the negative effects of substance use, offering treatment and assessing if someone's interested in treatment, and then increasing emphasis on other aspects of brain health that you'll already probably be doing in your older adults, but become extra important when that person has cognitive impairment and using substances. And so that includes talking about medications, discussing isolation and their social networks, and involving the caregiver. So first, we recommend providing universal education about the effects of drug and alcohol on the brain and health to all patients and caregivers. And often I like to start with an open-ended question or asking permission. Can I share some information about the impact of alcohol on the health of the brain and memory? And that can start to provide a little bit of information to caregivers and patients. Trevani already went over this, but are there safer use limits in older adults? And there likely are not, although not everyone wants to stop completely, and that's okay. Less can be better. And so if someone is using more than the safer drinking limits for older adults, often recommending to cut back as a starting point to no more than 3 drinks in a day or 7 drinks in a week. We have a lot less information about non-alcohol substances, but again, likely there is no safer use limit, particularly for older adults with cognitive impairment. I'm going to move on to discussing harm reduction with patients. So harm reduction is an approach that focuses on that the goal does not have to be complete abstinence. That may not be everyone's goals, and in some instances that may not even be necessary. And so it's okay to step back and really focus on the negative effects of a substance and how we can support someone in improving their quality of life and meeting their other health goals and reducing the harms of substance use. And that starts with full-on respect, for they are the experts of their own life and body and health, and we respect their difference in values and goals. Some of general practices on harm reduction are cutting back is a great start and can have positive health effects. Using in the presence of others, which is particularly important in older adults who may be more prone to experiencing oversedation from substance use or risk of falls. And we know using the presence of others is important in reducing overdose risk, especially if someone, if they have naloxone on hand and the individual knows they could be using an opioid opioid. We recommend supporting people and strategies to make sure they're getting adequate nutrition and hydration and sleep. We know substance use can impact someone's desire or time to eat an adequate meal or drink enough water, which is extra important to mitigate some of the negative effects of that substance. And several substances can affect sleep. And so brainstorming with that individual how to map out a time in their day when they're going to use a substance and support time for sleep and support time from recovering from a substance. Talking with someone about the situation, the physical environment in which they're using, and how to reduce the risk of physical injuries, including how they're going to get home from when they go out, or not having to drive when someone's consuming a substance. And then we recommend providing naloxone education and prescription for all patients and caregivers who may be at risk of opioid overdose. The National Harm Reduction Coalition has a world of resources, more about harm reduction and more substance specific recommendations, but these are some general best practices. Next, I'm going to move on to discussing treatment with everyone and assessing if someone is interested and then offering it. So treatment is very effective and desired. And in particular, we do have good evidence that older adults, despite what others may think, are interested in treatment and can benefit from it. Despite that, they do experience barriers to treatment, and interventions do need to be adapted based on individual physical or cognitive or psychosocial needs. Treatment can include medications, which I'll discuss more in just a moment, and behavioral interventions, which I'll also discuss how to adapt those for older individuals, and harm reduction is part of treatment. We know older adults, the vast majority of which in this country are covered by Medicare, have particular insurance barriers. Medicare, in most cases, doesn't cover residential treatment or intensive outpatient treatment. There's a lot of movement to change that, and so hopefully we'll see some change in the future. Medication coverage can be a challenge, knowing that different Part D plans may cover certain formulations and not others. Medicare does cover treatment in an opioid treatment program. So someone, if they're interested in methadone or getting buprenorphine from an opioid treatment program, that is covered by Medicare. And that said, we know many of you are seeing older adults with cognitive impairment who are using substances. And really our goal is to promote this idea that no wrong door is every door should be the right door for treatment. And so providing a little bit of resources for you all to provide that treatment in primary care or whatever your practice setting is our goal today. And most of these interventions can be done in a primary care setting. So first, I'm going to talk about medications for alcohol use disorder and how we think about those in someone who may be experiencing cognitive impairment. The big takeaway is these are very effective and should be considered and offered to everyone who's interested. The first line medication really is naltrexone, which is generally very safe and well tolerated, even in older individuals with cognitive impairment. We can't use it in someone who's using opioids because it will block that effect. And you should use it with monitoring in someone with liver disease. But generally that should be your go-to agent. Acamprosate is another option. The one downside to that is that it's 2 pills 3 times a day. We know a lot of what we're balancing is polypharmacy. And then disulfiram or antabuse really depends on the patient's goals. It can be effective if it's given in a monitored setting. That said, it's generally not recommended for individuals with cognitive impairment because of, someone may not remember if they took it or may not fully grasp what's going to happen if they do drink after they've taken it. And then the effects if someone does drink while they're on disulfiram can be really uncomfortable, especially if someone's older and has other medical comorbidities. So it's generally not recommended. Topiramate is an off-label medication for alcohol use disorder and can be very effective, although we know it has cognitive side effects. And so generally, if someone's already experiencing problems with cognition, is likely not recommended. And then gabapentin is also very helpful for alcohol cravings and some mild alcohol withdrawal symptoms, although we know most often it's effective at TID dosing at 3 times a day, and then we need to balance the sedating side effects. Next slide. The big takeaway though is medications are effective. Naltrexone really should be your first line of treatment due to its side effect profile and safety. And that can be given in both the oral formulation and the injectable intramuscular once monthly formulation. Both are just as effective. Other medications should be considered, although you are weighing some risks and benefits with polypharmacy and other sedating or cognitive side effects. For alcohol, the other thing to consider is that individuals who are using alcohol on a regular basis at high quantities are at risk of withdrawal, and older adults are at higher risk of complicated withdrawal syndromes. If someone has an alcohol use disorder, is drinking regularly, has experienced withdrawal in the past, and has cognitive impairment, we'd strongly recommend that you consider an inpatient medically supervised withdrawal setting. And that may depend, the ability to do that may depend on where you practice. And so getting help from a local specialist and local resources to assess the need and where someone can obtain withdrawal management in a medically supervised setting. Next, I'm going to talk about medications for opioid use disorder. The big takeaway from these are they're highly effective. They reduce all-cause mortality by 50% and should be considered for all patients with opioid use disorder. Methadone and buprenorphine are full agonists. I know in general, we're trying to avoid full agonists in older adults because of the cognitive side effects. That said, if someone has an opioid use disorder, is misusing pills or is using heroin or fentanyl, these are significantly safer and you should really consider treatment with buprenorphine or methadone. For methadone, it's highly effective and safe when it's given by an experienced clinician. We do need to monitor for drug-drug interactions. There are several, and there can be sedating side effects when it's not dosed appropriately and it needs to be monitored for sedation. And we know there can be some challenges with various comorbidities. If someone is interested in methadone, they can benefit from the support and structure of an opioid treatment program. And I recognize that not everyone will have access to that, and that does require frequent clinic visits. If someone is starting methadone for opioid use disorder often and they're older and have cognitive impairment, potentially starting at lower doses with a slower dose titration. But again, when it's monitored and provided by an experienced clinician is still very safe in an older adult. For buprenorphine, it's generally very safe and you may need to start at lower doses and titrate slowly like you do with so many other medications for our older population. And then the last medication option is the once monthly injectable naltrexone, which is generally well tolerated, although its effectiveness can be limited because it's challenging to start for someone who's using opioids, and there are lower rates of a retention and potential overdose risk after stopping the medication due to loss of tolerance. And for opioid use disorder, only the once monthly injectable muscular formulation of naltrexone has been shown to be effective. So the big takeaway for medications for opioid use disorder is that medication treatment really should be offered to everyone, regardless of cognitive impairment, given their significant benefit, particularly with the 50% reduction in mortality risk. The choice of medication may depend on the individual's desire and their comorbidities. In general, buprenorphine may be more preferable given its side effect profile. And then, the big news for 2023 is that every single one of you on this call who has a DEA license can prescribe buprenorphine right now. You do not need to attend a special X waiver training. You do not need to apply for a waiver online. This was the Consolidated Appropriation Act of 2023. There's no longer a limit on the number of patients you can treat with buprenorphine. Counseling is not required. What will happen is next time you go to renew your DEA license, so next when it's set to expire on its regular schedule, you'll have the option to select one of the following options to certify that you've attended some training on opioid use disorder and substance use disorder. If you've previously completed the X waiver training, you're good to go. If you're board certified in addiction medicine or addiction psychiatry, you're good. If you've graduated from your training program in the last 5 years and your program had 8 hours of training on substance use disorders, that qualifies. And then the last option is if you've completed 8 hours of training on substance use disorder from an approved organization. And the list of approved organizations includes any organization that also can give out, that's approved by the American College of Continuing Medical Education. So if you're getting CME for something on substance use disorder or opioid use disorder, this counts towards those 8 hours. This law doesn't override any state laws. Each state has a little bit of unique differences, although the vast majority, this law, the federal law, was the more limiting law. So go and prescribe buprenorphine, and there's some resources at the end if you're still needing some more information on how to do that. And then medications for other substance use disorders. There's no FDA approved medications. For stimulant use disorder, there's a couple small studies that have shown some potential benefit from mirtazapine or bupropion plus IM naltrexone. So you could consider these, especially if someone has co-occurring depression or anxiety. For benzodiazepine use disorder, really providing wraparound support for someone's anxiety or insomnia, which we know often comes with the benzo use, and then also identifying the risk of withdrawal and supporting that individual in engaging withdrawal management if needed. And then there's no FDA approved medications for cannabis use disorder. Our treatment includes harm reduction, which we've reviewed, medications, and it also can include behavioral treatment. And these still can be effective for individuals with cognitive impairment, although they need to be adapted to that individual's needs. And we recognize, everyone's unique. Not everyone's going to need adaptations. Some may need a lot. And we respect that there are differences in experiences and values. Some options include thinking about if someone would benefit from a group setting versus individual. A group setting can be really helpful because it brings a community of people together who often have common experiences or may have common experiences. Although some people may have a challenge participating in a group due to their ability to focus or challenges in hearing or differences in language. There are senior specific groups. There's one called Seniors in Sobriety, which is based off the AA model. And often a lot of the mutual aid groups have they're each their own individual unique flavor. And so finding one that may be more applicable to the experiences that an older adult may be having, including retirement or loss or loneliness. The beautiful option is a lot of these have the ability to do telehealth and some are in person. And so some people really like getting out of the home, going to see people regularly, and others may benefit from being able to do it over the phone or video. And maybe even some would benefit from home visits as well. Some adaptations to consider for those experiencing cognitive impairment include going at a slower pace, repetition, and shorter session lengths. And then for program materials, people learn and retain in different ways. And so some people, especially those who are struggling with memory, bringing something home, whether it's a visual with simple pictures and language. Some people learn best by audio recordings. And so offering to record the takeaway points or the next steps can be really helpful for individuals. And then we recognize these programs should adapt for other needs. And so assessing if someone can participate or needs an adaptation due to hearing or visual or physical needs. And then really, as I mentioned before, looking for age-specific peer support groups that can talk about topics that are more relevant to what's going on in your individual patient's life. Lastly, I'm going to move on to an increasing emphasis on other aspects of brain health. First, we'll talk about medications. We all know in our older individuals, the medications can build up. There's a lot of polypharmacy, and because someone's aging, how they metabolize the medication changes. And so they're more at risk of some of the negative effects, particularly cognitive effects. So as always, and this is increasingly important if someone's using a substance, deprescribe unnecessary medications, simplify the medication regimen. In particular, we want to identify the medications that may have cognitive side effects, which are extra heightened if someone's also using a psychoactive substance. And so you can check out the Beers criteria. It was updated in 2019 if you're wondering if a potential medication may have some cognitive side effects, and really prioritizing those as the first ones to deprescribe, recognizing you're going to weigh the risks and benefits of stopping that medication. A big topic and a big challenge, and really warrants a whole, presentation in of itself, is for individuals who are prescribed chronic opioids or chronic benzodiazepines, and now are developing some harm from it or developing cognitive impairment, and you're worried about safe use. It can be a challenging situation. I recommend weighing the risks and benefits of stopping and the risks and benefits of continuing. There are risks to stopping or tapering those medications without buy-in from the patient. And so really, I recommend that unless there's imminent safety concerns, taking the time to get patient buy-in to a tapering or stopping of those medications, which I know can take months, years, even small changes can be impactful. And while you're doing that, building up other supports and treatment options for addressing their underlying chronic pain, insomnia, anxiety. And so that I'd love to dive into that more in another setting, because it's really important in our older adults, and there's some nuances to it. Next, we want to talk about social networks and isolation. A lot of our older adults are experiencing isolation, which we know can drive substance use. We also know all of our social networks can impact our health-related behaviors, including substance use. And so for some individuals, they may be in a retirement community where a couple glasses of wine or beer are regularly served with a meal. And so recognizing that both social isolation and social networks can contribute to more or less substance use. However, social networks can really be an area for positive change. And so working with that individual to identify what are their goals and who are the people in their life, the ways that can support that for positive change. And one option is, mutual aid groups focused on recovery or focused on substance use really can combat isolation. So maybe one avenue to address isolation for individuals using substances. And then the last area I want to focus on is caregivers. Caregivers, involving them in treatment improves outcomes. Although we know that substance use, there's a lot of stigma that goes along with it. And so really asking permission still of the patient, if it's okay that if we involve the caregiver in the discussion, in the plan, and getting their permission and respecting that. We also recognize that caregivers' role in substance use can be complex, including they may have their own shame and stigma about substance use. They may be using a substance themselves or purchasing it for the individual. And in some instances, they may be giving it to the individual to sedate them or to have them go to sleep. And so what we recommend is, eliciting the caregiver's perspective as well, and then providing education and resources to both the patient and the caregiver. And then no need to place the burden of the plan on the caregiver. Really what you're focused on is the safety of the individual, and then coming up with a treatment plan together and eliciting how they can support each other in that plan. And then lastly, we know caregivers need support. They have their own unique stresses and again, maybe experiencing mental health or substance use themselves. And so connecting caregivers to support it can be an important part of the plan as well. So let's come back to Jessie. So as a refresher, Jessie's our 72-year-old patient who's having cognitive changes. At your last visit, you assessed their substance use and determined that his alcohol use meets criteria for an alcohol use disorder. So let's continue that conversation with Jessie. Okay. And as a reminder, Triveni's the clinician and I'm the patient.
Jessie, it's good to see you back today. Is it okay if we talk more about your drinking?
Yeah, I've been trying to cut back. It hasn't been going well. I need help. My daughter's here too, and I know she agrees with me. I don't want her to feel like this is all on her.
Thank you for sharing that. Do you want me to talk more at this point about different treatment options?
Yeah, but do you mean pills? Are they safe?
Good question. We do have good treatment options, including medications to help people to cut back or stop drinking. And there's also counseling supports. Are you interested in learning more about either of those?
Do you mean AA groups? I can't really hear well in groups, and it's hard for me to get out of the apartment regularly. And I really don't want to be in a group with a bunch of youngins.
AA is one option. It's not for everyone. And there's programs for people who have similar concerns as you, like people who've lost a spouse or feeling lonely or seniors.
No, I don't think I want to go to a group or program, but you said medications. What are those? Are they safe? I mean, I take a lot of pills already. I guess I could maybe take one more.
The medication I would recommend, it's called naltrexone, and it's safe with your medical conditions and the other medications that you take. And it doesn't cause any harm if you take it while you're drinking.
Yeah, I could take a pill, just add it to my pill bottles. So some people still drink while they're taking this medication. I want to stop, and I know it'd be good for my thinking and memory, but just in case, and I probably still want to have a drink or two at game night.
You have a clear goal.
Yeah, I think I can do it when I'm on my own. And when I'm on my own, it's not good for me to drink. So I think I should focus on that. And when I'm around others, I think I can control myself more.
That's a great point. Drinking when you're around others is usually safer too.
And my daughter's shaking her head. She also told me she wants to start visiting me every Monday, and we're going to check in at dinner time most nights.
There are a lot of healthy ideas here. Can I summarize the plan?
Yeah.
You're going to start taking naltrexone, and your goal is to not drink alone. Your daughter is going to support this plan. She's going to visit you and try to call you regularly, especially during dinner time. We've talked about a lot, And I'll give you a summary of what we talked about as a reference for later. So I could record a voice memo or write it out for you or give a copy to your daughter too, whatever works best for you. And let's have a follow-up visit in about a month and check in on this plan and see if either of you want more support or resources.
Thank you.
And see you.
And I'm going to go over some key points and resources, and then we'll open it up to some questions. So our key takeaways from today are that we hope we presented a way to assess for unhealthy substance use in older adults, given its effect on cognition. And we wanted to model a non-stigmatizing approach to focus on how substance use and co-occurring mental health disorders can affect overall health and well-being. We recommend educating all patients and caregivers about unhealthy substance use, and medication treatment and harm reduction should be offered to all older people with substance use disorders and cognitive impairment. We included in the slides some key references. There's several from the Substance Abuse and Mental Health Services Administration that are really specific to treatment of substance use in older adults. And on the next slide, there's also some about how to start buprenorphine and a little bit information on the elimination of the X waiver and the Dementia Care Aware site that Triveni mentioned earlier. And then we included our emails here. You're welcome to reach out to either one of us or to the National Clinician Consultation Center. I highly recommend calling the NCCC. They provide a lot of great advice about patient-specific questions. And they have several different warm lines that you can call related to substance use and other warm lines. And at this point, I think we'll open up to questions, and we'll turn over to Brenda, who I think has been moderating the questions and can summarize them for us.
Absolutely. Thank you, Dr. Soren and Dr. DeFries. This was a great presentation today. We do have a few questions in our Q&A that I'd be great to have your perspective on. The first question we've received is, why are the recommended drink limits based on sex and gender?
It's a great question. I can take that one. Interestingly, there's actually pretty significant differences in the absorption of alcohol based on sex. And so studies have shown with even the same amounts of alcohol that men and women absorb them in their GI tract and their stomachs at very different rates. So that's the reason for those differences based on sex and also based on age. You know, we mentioned a couple of times in the presentation how people's metabolism of substances, including alcohol, changes as they age.
And we should mention that drinking limits are based on cisgendered individuals. And so recognizing that isn't fully inclusive of transgender individuals.
Great. Thank you so much. Our next question comes from Walla Walla, Washington. We have an individual who works at the VA, and their question is with regard to the aging baby boomer population. They're seeing an increased amount of patients who are aging and have substance use disorder. However, this population also has a number of comorbid medical and mental health conditions, including mobility conditions, difficulty with activities of daily living, et cetera, to early signs of dementia. And so this individual expresses that they've been having a difficult time both in the substance use disorder inpatient treatment setting, as well as finding discharge environments. We were hoping that maybe you could speak to how we might be able to find any advice on working with these patients and finding opportunities for placement.
Go for it, Triveni. That's such a complex question and important one, so I'm glad you're asking it.
It's super important. It varies by where you're located a lot. I would say we're fairly lucky where Christy and I practice in Northern California, but this is not the case in the entire country. There are some good publications out there that you can reference about the accessibility of medications for OUD in skilled nursing facilities, and there's a lot of advocacy that's been done in this area. One of the really helpful things to come out of this advocacy is actually something new from the American Disabilities Act. And so last year, it now is qualified as an ADA qualification to have opioid use disorder if you are not using illicit opioids and you're on treatment. So your patient with OUD who's on methadone or buprenorphine and needs to go to a SNF actually has a disability, and there's a necessity for the facility to be able to accommodate their disability. So that's a really helpful thing to reference, and you can find the ADA language online.
And I would add, this area is ripe for advocacy, because you're totally right that a lot of substance use treatment facilities, especially when someone has cognitive mobility challenges, say they can't accommodate. And then a lot of the nursing home facilities are saying we can't accommodate their substance use or their behavioral problems. And so ripe for advocacy, because we are going to see more of this. We have an aging population and they're increasing substance use. So let's all band together and advocate that these treatment settings need to be able to address these concerns as well.
That's great. We have a question with regard to oral healthcare providers. Someone was quite curious if we receive calls on the substance use warm line from oral healthcare providers.
A really great question. As one of the clinician consultants on the warm line that you might reach, I don't think I have received a call from an oral health provider, but I'm very open to it. I know as a primary care doctor, my patients are seen at different dentist office, and questions come up about opioids, especially because sometimes they're prescribed pain medications after surgery or procedure. So feel free to call. Any clinician can call the substance use warm line for advice.
Great.
And I would add that I practice in an opioid treatment program or opiate outpatient buprenorphine clinic. And so many patients have oral health needs that are not addressed. And so I love that there's oral health providers on this call, because stigma is faced in all healthcare settings, and a lot of people feel shame about their oral health, and it can contribute to pain and infections. And so I think someone asked about a motivational interviewing approach. Like, love it. Please, like, respect, non-judgment, and a destigmatized approach to care is so important in every setting. And we know that substances can negatively impact oral health. So keep it up, our oral healthcare providers, and definitely call the warm line.
Thank you. I'm hoping it's okay. We're about 2 minutes over, and we have just maybe a couple more questions, if that's okay. The next question we have in our Q&A is with regard to one, confirming that Vivitrol injectable is covered by Medicare. And then we have another question just with regard to the dosing recommendations for buprenorphine for older adults with cognitive impairment.
Great questions. So the question about injectable naltrexone will vary by plan. So I can't answer that universally. I believe the vast majority of plans cover the oral naltrexone formulation. But again, I can't answer specifically about individual Medicare Part D plans for injectable naltrexone. It is more expensive, so there may be scenarios where it's not covered. If it is for alcohol use disorder, recognizing that taking another pill every day may be hard for some people, but the oral formulation is also well tolerated and just as effective. For opioid use disorder, it's not indicated, so it'll vary plan by plan. I know for our Medicaid population in California, injectable naltrexone is covered for both. So at different states, we'll have different options as well. And then buprenorphine dosing for older individuals. It's a great question. In general, I think with all medications, starting at a little bit lower dose and titrating up more slowly, and then more frequent checkpoints as you're adjusting the dose, I think would be particularly helpful. That said, if an older adult is using fentanyl, is using a really strong, potent full agonist, they're probably going to need high doses of buprenorphine, and that's okay. The main side effects that we should look out for is most people actually feel activated or a little energy from it. Some people feel sedation, and so you need to kind of counsel the individual that I'm not sure what their individual body will experience, but if they're experiencing particularly sedation or uncomfortable activation from it, that we may want to reduce their dose. But the vast majority of people tolerate it quite well. If someone's transitioning from opioid pills, they may need lower doses. And so just starting low and giving them the option to titrate up to therapeutic doses while monitoring for side effects. But again, in general, they'll need similar doses to younger adults as well. And close follow-up can be helpful in finding what the right dose for that individual is.
Why don't we, we'll throw in one more question, then I apologize. I think we will need to refer people to contact us through our substance use warm line. We'll try to save the Q&A as well. and reach out to invite you to contact us as well on the substance use warm line. I think for our last question, with regard to alcohol screening, do you recommend that this should be done as a routine for all older adults as a routine, since you mentioned the invisible patient?
Great question. I think this is going to come up in different ways, and screening is an option. Like I said, it works better for some patients rather than others. A lot of your clinic settings are going to have standardized approaches to screening. And so, in the primary care clinic where I work, folks are getting a once a year annual behavioral health screen that includes the single question alcohol screener on it. So you may be meeting patients who are already getting that screening done in some kind of automatic fashion. I think it's a great idea to think about annual screening for patients, including older adults, because even though some of the guidelines extend to just adults generally, like I said, as they age, things are going to change. And so someone who may have had a negative screen before or been using lower levels of alcohol may be having some more issues with it. So I would definitely work this into your conversation, whether you use an actual screening questionnaire or just some more open-ended conversation about an annual basis with your patients.
And then I'd add, if someone does newly have cognitive problems or concern for dementia, we strongly recommend you assess substance use, recognizing the impact of substances on both drivers for cognition, but also their long-term brain health.
Again, thank you to Doctors Soren and DeFries. We are 6 minutes after the hour, and it seems like we have a lot of enthusiasm for this topic. We kindly ask that you please take a moment to fill out our brief confidential survey. This also is how you'll be able to request your continuing education. We will be sending a recording link to everybody that attended today's webinar, as well as those who have registered. We kindly thank you for joining us today, and we wish everyone a fantastic day.